All right, I'm Emily Speer. I am a foregut surgeon here locally in Denver at National Jewish and St. Joseph Hospital. I'd like to thank SAGES and our moderators for the opportunity to present the updates in the diagnosis and preoperative evaluation of GERD. I have no disclosures. Today I'll talk about the evolving definition of GERD, the most common tools in our toolbox for diagnosing GERD, and future considerations for preoperative evaluation. So defining GERD, for decades, GERD was previously defined subjectively by symptoms, which muddied the waters when studying prevalence and response to treatments and therapies, just kind of how Dr. Dirks was just alluding to. There's been a huge push through multiple expert consensus statements and meetings to attempt to more clearly define GERD. And most recently, the Lyon consensus in 2018 defined GERD as you can see here. They also concluded that GERD can be diagnosed with pH testing or endoscopic findings of LA grade C or D esophagitis, peptic strictures, or greater than a centimeter of Barrett's esophagus. GERD is no longer considered to be a just a simple one-size-fits-all disease. We know there are a number of different factors that play into the multifaceted pathophysiology of GERD, and pre-op testing is really aimed at defining each patient's individual GERD phenotype in order to tailor their treatment options and rule out alternative diagnoses, and it can also be used to monitor post-operative treatment response. We have all seen this pump valve reservoir diagram where if a piece of the machine isn't working, it can backflow. And in GERD, you can have inefficient esophageal clearance, you can have a mechanically defective GE junction, or abnormalities of the gastric reservoir, such as progressive shortening of the sphincter with distension, or transient loss of the sphincter barrier. And this multifaceted pathophysiology is one of the things that the Lyon consensus emphasized. So their two main goals were to determine the indications for different esophageal tests for GERD, recognizing that each patient has this unique GERD phenotype, and they built upon the Porto consensus to try to clearly define the criteria for a GERD diagnosis, and this was through objective testing again, saying that subjective symptoms were insufficient for diagnosing GERD. And it's important to note that their goal was just to define GERD, not necessarily to change the indications for anti-reflux surgery. So upper GI is one of the tools in our armamentarium for preoperative workup, and it's the best test to diagnose hiatal hernias. Multiple studies have demonstrated the low sensitivity and specificity of endoscopy for diagnosing hiatal hernias compared to upper GI. Upper GI is great for diagnosing really severe abnormalities in esophageal body function with a 94% sensitivity for achalasia, a 100% sensitivity for scleroderma, but it's pretty unreliable for diagnosing less severe motility abnormalities. There was a retrospective study that evaluated 281 patients at a single center who underwent esophagram within the same 90 days of manometry, and they demonstrated significant disagreement between the two studies. So the sensitivity and specificity of esophagram for detecting esophageal dysmotility were 0.69 and 0.50 respectively. So manometry is still the test of choice for assessing esophageal body function. Upper GI is also unreliable for diagnosing GERD with a low sensitivity and specificity. Patients without GERD can have episodes of gastroesophageal reflux disease on the table with provocative measures, and then esophago-esophageal reflux can be misinterpreted as gastroesophageal reflux. A marshmallow bagel upper GI study, however, is really useful for evaluating motility. This is a 2019 study with Lipham's group that was published in Surgendo, and they looked at 418 patients who underwent both pre-op protocolized videoesophagram with a solid food bolus as well as manometry. And the negative predictive value of videoesophagram was 99.6%, and the sensitivity was 96.4%, and they concluded that patients who had a normal food protocolized videoesophagram could forego preoperative manometry since the correlation was so good. So perhaps the one test that all experts can agree upon is absolutely necessary prior to anti-reflux surgery is endoscopy. So this one's pretty easy. It allows direct visualization of the esophageal mucosa. It's currently the only reliable method for the diagnosis of Barrett's esophagus and esophageal adenocarcinoma. And again, to recap, the Lyon consensus did conclude that if you have any of the findings shown here on this slide, that it does secure a GERD diagnosis. One endoscopy pitfall is trying to use direct laryngoscopy to diagnose GERD, and I know we've all gotten these referrals before. We know that direct laryngoscopy has a low sensitivity and specificity for diagnosing GERD and poor inter-observer concordance. This is actually one study that showed that 93% of patients without GERD were actually found to have inflammation of the vocal cords on direct laryngoscopy. Some endoscopy adjuncts are things like narrowband imaging to help visualize Barrett's and esophageal lesions. Confocal laser endomicroscopy is a probe-based study that gives you some real-time bedside visualization of the microscopic surfaces of the mucosa, and you can help identify Barrett's esophagus and dysplasia and malignancy real-time. Another endoscopy adjunct is wide-angle transepithelial sampling with computer-assisted analysis, or WATS 3D, and you place a stiff brush through the working channel of the endoscope to just circumferentially collect transepithelial specimens from the lower esophagus, and it increases the diagnosis of Barrett's esophagus and dysplasia significantly. And then there are also multiple swallowable devices you can see here. There's little devices on strings, like this sponge capsule that you swallow. It expands, and then you pull it out the mouth, and it collects esophageal samples to help detect things like Barrett's esophagus, and then you can see some other swallowable devices off to the right there. Next, pH testing. It's a very important tool in the toolbox for preoperative workup, and I think first and foremost, it's important to state that pH testing should be done off antacids for about 7 days for the diagnosis of GERD, unless you clearly have a diagnosis of GERD on endoscopy findings, and this is a recommendation of SAGES, ACG, the Lyon consensus, and really is no longer a debate. You're mainly looking at Demeester score and percent time. pH testing adjuncts that are of clinical interest but are not diagnostic for GERD are things like symptom index, symptom association probability, total reflux events, nocturnal baseline impedance. And then, this is pretty basic, but there are two most widely available pH tests are the catheter-based pH impedance test, which measures both acid and non-acid reflux. It can measure both proximal and distal reflux, which can be interesting when you're trying to look at proximal extension of reflux events and how they might correlate with extraesophageal symptoms. And then for patients with nickel allergies, the plain pH catheter without the nickel-containing impedance probe is a good alternative. And then the second most widely available pH test is a wireless probe, which has the advantage of avoiding a catheter hanging out of your nose for 24 hours, and it can measure up to 96 hours of data, but so far only really measures acid regurgitation. An interesting newer device for measuring GERD is a mucosal integrity balloon, and this goes down the esophagus during endoscopy and detects changes in the conductivity of the esophageal epithelium. And so impedance is inversely related to dilation of the intercellular spaces and is a signal of mucosal damage. So the interesting thing about this test is that it measures the end result of GERD, namely mucosal damage, as opposed to being variable day to day as pH tests are, as we know. And this was a study of 69 patients who underwent mucosal impedance. It showed statistically significant correlation with certain waveforms in patients with no GERD, with GERD, and with EOE, so it is promising. Finally, manometry. This is a controversial topic, and if you attended the esophageal physiology session, you know there's a lot of controversy surrounding this. But there have been multiple guidelines, societies, and consensus statements stating that pre-op manometry should be mandatory prior to any anti-reflux surgery. It's a recommendation of the ACG guidelines, of the ISDE guidelines, JAC's expert consensus, ICARUS international consensus, but SAGES and AFS, we've been relatively quiet on this forefront, largely because of the reluctance to kind of back our colleagues into a corner without any super solid A+ data, and the fact that there are always exceptional cases. But despite this, I think there's no arguing that manometry plays a really vital role in preoperative workup. It can localize the LES for pH impedance probe placement. It can assess the esophageal body and EGJ mechanisms, contributing to reflux, helping you figure out the so-called GERD phenotype of your patient. It can exclude conditions that mimic GERD, such as achalasia, which is found in 1 to 3% of patients who present with GERD, supposed GERD, and also aperistalsis, which is found in up to 3% of patients referred for surgery. We know that impaired peristalsis is found in up to 17% of patients, so motility disorders are not uncommon in this population. And then manometry is great because it can help tailor treatment approach, whether it's pharmaceutical, endoluminal, surgical. Additionally, manometry can help identify EGJ morphology, which is basically how the LES and the crural diaphragm overlap, and that morphology can actually help predict GERD. This was a study of 130 patients with suspected GERD who underwent mano and pH testing off antacids. And of patients with type 1 morphology, only 50% who presented with GERD symptoms actually had objective GERD on pH testing. And then this increased to 84 and 95% with types 2 and 3 morphology, respectively. So increasing separation between the LES and the crural diaphragm can cause a gradual significant increase in reflux. And then endoflip, I have seen this exact picture like I think no less than 10 times during SAGES. But endoflip is the newer way to assess motility, and it looks at cross-sectional area and distensibility index. And at present, it's not validated for diagnosing GERD. Some GERD patients have an increased distensibility index, others show decreased distensibility index. But there was a study of 111 patients who had normal motility on endoflip. And of those patients with normal motility on endoflip, 70% actually had normal manometry, so it's fairly good correlation. And I think it's still too early for endoflip to replace manometry, but it is promising, and there are some definite roles for it. We all know that patients do not enjoy GERD surgery workup. There's a lot of expert consensus about what should be done prior to anti-reflux surgery, but really not a lot of high-powered data to support that one way or another. But as the future of technology improves, I can envision something like bringing my patient in for an EGD, performing an endoflip to assess motility, and then doing a mucosal integrity test to assess for GERD, and then completing this full preoperative workup in the course of a 20-minute EGD. So with new and developing technology, there is hope for our patients that a quicker and gentler GERD workup is on the horizon. Thank you.